everyone. Welcome back to the Gyno Gurus podcast. As promised, today we're going to be doing something a little bit different. So if you watched our last two series or episodes, we've been doing a series over insulin resistance, and we had kind of briefly talked about if we were going through a topic and had a particular patient case that we felt would be helpful to present, just so you guys could see real-time interventions and how it actually works, with the patient's permission, of course, we would, try to do that. And as we were going through insulin resistance and just kind of talking about it, I had a particular case that came to my mind that I really wanted to share with you guys. And I think it's the perfect time to do it because we're kind of in the middle of our series. I think we have 2 episodes left of it. So so it'll be 4 total episodes of the insulin resistance series. And then we'll have this little clinical discussion or clinical conversation in the middle of it. So I'll just kind of start by giving y'all a background of this patient, who she is, why she came to see me. So this patient was a 24-year-old female, so healthy BMI of 24. So her initial purpose to come visit me, so she came in for her annual, but when we were just talking, seeing how she was doing, she had told me that she was having kind of just some unpleasant symptoms. She kind of described it really just as not feeling good. That was really kind of the quote that we stuck to as we were trying to figure out what was going on with her. She was just like, I just don't feel well. I don't feel like myself. So really just what that entailed for her was mood swings, irritability, which is very frustrating for her because she just felt like she wasn't completely in control of her emotions. And it was just very difficult. And along with that, she also was having somewhat irregular menstrual cycles, and then just some other kind of non-specific symptoms as well. But really the main, what we kind of call in medicine, the chief complaint, like why you're coming in to see me for her, was really the brain fog, the fog, the mood swings, and just generally not feeling well. And then the kind of irregular menstrual cycles were more of a, I would say, clue to me more than anything. I wouldn't say that was necessarily like her main complaint, but it was something that kind of cued me into what might be going on, if that makes sense. So after talking to the patient, we had kind of decided that a device called Mira, which we'll kind of talk about what Mira is in a second, but we had decided that Mira might be a good idea for her to basically kind of just track her cycles over a few months, basically see if and when she was ovulating. If I remember correctly, I think that she had maybe one cycle that was over 35 days long, because really that's kind of our range, anywhere from 21 to 35 days from the start of your first bleed to the start of your next bleed. That's considered a full menstrual cycle. So 21 to 35 days is normal. I think that she had only really one cycle that was kind of out of that range. But there was just other stuff going on that kind of just inclined me to look a little bit deeper to see, is she ovulating or is there hormonal balance? Like what's going on? So we're going to have her charts on the screen somewhere, probably here or here. And I'm just going to kind of explain to you guys what you're seeing. So this is what a typical Mira monitor chart will look like. So basically on her chart, you have the gray line, which is the urine metabolite of estrogen. You have the purple line, which is the urine metabolite of progesterone. And then you have the light blue line, which is LH. So each of these hormones are very important in, a healthy menstrual cycle. And whenever we're tracking on Mira, I think we haven't mentioned this before, but basically you're looking for patterns, not one single data point. So I've had people ask me before who are just started either using Anito or Mira, and if you've been on TikTok or Instagram, you know what those things are. And they've done one test of it, and they're like, is this normal? And I'm just like, well, we don't know yet because we don't have enough data. So you have to keep testing, and, it's more of a pattern. It's not really the same thing as like a serum blood draw, which we, order from, your doctor, provider, whatever. So basically what you see here is that she looks like she is ovulating very late. Can you zoom in on that for me, Logan, just so I can see exactly what day it is? So on her first cycle, and this is her cycle number 1, we'll show you guys all 3 cycles. So she had roughly a 22 to 23 day long follicular phase, which is very long. And a follicular phase is basically the time that it takes for you to make an egg and for it to ovulate. And then after you ovulate, you begin something called your luteal phase. So a very long follicular phase, like 23 days long, was a kind of a red flag to me, just because typically what I like to see is my patients ovulate around really day 12 to 18, somewhere in that range. And anything longer or shorter can indicate some type, like basically that there's some type of poor follicular function going on. It doesn't give you a reason why. It just kind of says like, hey, like this might be happening. So that was my first clue that, hey, like something might be going on. But something else that's interesting that you can see on her chart, on the first chart, is that the purple line, after she had her little LH peak, we call it, on cycle day 22 to 23, you can see the purple line shoot straight up. And that means that she did successfully ovulate that cycle. So that means that her progesterone is on the rise, which means that there was a successful formation of something called the corpus luteum. And the corpus luteum is a cyst structure on the ovary that produces progesterone. It's a healthy physiologic part of ovulation. You want that to occur. That's why I think some people, whenever they think of cysts on their ovaries, are like, oh my goodness, that's so scary. But having a corpus luteum cyst is a good thing. You want that because that's how you're able to, produce a healthy lining for, potential baby to implant and carry a healthy early pregnancy. So that's just kind of a little tidbit of information there, not really relevant to what we're talking about. But anyway, moving on. So, and then I guess to finish up with her first cycle, she did have a healthy luteal phase, which was about 10 days long. Well, 10 days long. It was still on the shorter end. It was the healthiest one that she had before we started treatment. And just to kind of also give you guys a little bit more information about luteal phase, clinicians will differ in their preferences for what's considered normal or optimal. I usually honestly like to see luteal phases lasting really longer than 12 days if I'm being picky. I mean, I think the literature says 11 days is fine, but I personally like to see it between 12 and 14. So she is a little bit short on the luteal phase, which means that she was probably lacking a little bit of progesterone, which, not to get too deep in the weeds, is traced back to poor follicular function. So moving on to her second cycle, we can see that she ovulated a little bit earlier, or she tried to ovulate a little bit earlier. So she did have her LH peak on day 20. And then if you remember the purple line that shot straight up after she ovulated the first cycle, that didn't quite happen this cycle. And she also had a very, very short luteal phase. So, and between the days of 22 and 26, she might have had a little bit more of a progesterone rise, but unlikely considering that she only had a 7-day long luteal phase. And that's very, very, very short, indicating that there is definitely some type of deficiency going on. So now we're moving on to cycle 3. So this cycle, we had no LH surge at all, no ovulation. This was an anovulatory cycle. As you can see on the chart, there's no rise in the light blue line, no rise in the purple line, which sometimes on Mira, obviously, because these devices are not perfect, sometimes it can miss your LH surge, but then you know that you ovulated after the purple line goes up. That did not happen here. So after we had basically kind of gathered these 3 charts, we really had some indication, or there was an indication that something was going on, that something wasn't quite in balance. So basically after we got her 3 cycles, kind of learned her trends, we jumped into doing the hormone profile, which I'm not going to go through all of that with you just because really the relevant things that we're talking about here are the insulin and the glucose. So the first set of labs that we did, she surprised me and actually had optimal labs. Everything looked so good and I was so confused. So just to highlight basically why I was confused. So high level, all of her, reproductive hormones look great. There was no really indicators, of something that would maybe cue us into something like PCOS. Her glucose level was 80. And if you remember back from our insulin resistance series, Dr. Mandel had talked about how he liked his glucose levels in his patients to be under 85. So we are below that. And then her fasting insulin level was 3. And if you remember back from our series, the optimal fasting insulin level is ideally, if I'm being picky, under 5 or under 10 is optimal. But even if I was being really picky here, being under 5, it was still under 5. So after we got all of these back, we were both kind of stumped. And then just to kind of briefly overview her imaging, there was like possibly, they said on the ultrasound, possible PCOM, which is polycystic ovarian morphology, on one of her ovaries, but it was very, very faint, and it wasn't anything that was like, this is definitely what this is. So again, it did maybe kind of give us a slight indication of what might going on, or what might have been going on, but it wasn't enough, and we just weren't sure. So after talking to this patient, I was like, listen, I know this is going to be a bummer for you, but I'm going to have to probably send you for the oral glucose tolerance test with insulin response, and you're probably going to be at the lab for 2.5 hours. And she was so willing and just enthusiastic to go, which I really appreciated because not everybody would feel that way. And that was really where we got our answer, which really just made me realize how important, number one, listening to your patient whenever they say something is wrong, something most of the time is wrong, and 2, basically not quitting whenever, everything looks great. So, your fasting insulin is normal. So it's like nothing would be wrong if we, tested your insulin response to 75 grams of glucose. It's like your fasting insulin is so optimal. And we'll put her basically OGTTi, which is an oral glucose tolerance test with insulin response, lab results, for you guys to see here as well. So basically here we have her fasting insulin was 7, so it was a little bit higher than the last time. And then after 75 grams of glucose, her insulin went from 7 to 161 in 30 minutes. And that, my friends, was the answer to all of our problems, come to find out. And so basically another interesting, fact about this, kind of going back to the conversations that we had over our series with Dr. Mandel. At the 120 mark, she was actually hypoglycemic. Hypoglycemia means that you have low blood sugar. So it just means low blood sugar. And if you remember the conversations that we had, basically, if you have a lot of insulin floating around and, not enough glucose, you are going to have something called reactive hypoglycemia. And that's exactly what happened here, which is very, very common with insulin resistance. So after this test, we had our answer. And, after extensive discussions with the patient, we had decided to really just take a more aggressive approach to her treatment, especially since she seemed to be having issues with ovulation. She just wasn't feeling good. And we just kind of went straight to, okay, let's try to just get us back on track, do a more aggressive treatment, and then kind of taper it down from there. So I ended up starting her on 1,500 milligrams of extended release metformin, basically to do that until consistent ovulation was occurring, and also just to see how she was feeling. So I think one thing with medication and any treatment, of course, unless it's something that the patient has to be on the treatment no matter what, you want to make sure that they're feeling good. And I didn't want her to be on something if she wasn't going to feel good on it. But to my surprise, and very, very thankful, she did very, very well on the metformin. Almost immediately, I would say. Of course, with metformin, if you've heard of anyone who's taken metformin before, it can cause some GI side effects early on, like nausea, diarrhea, stuff like that. But it's all pretty temporary. So if you can get through the first few weeks, it's usually okay. But after 3 months of being on the medication, her cycles have been regular. She's been ovulating on day anywhere from 14 to 16, having a beautiful progesterone rise. And she really started having regular cycles, I would say probably a month into taking metformin, but we didn't start tracking on Mira again until about 3 cycles in, just because if you've ever used Mira or Anito, the equipment's not free. So I didn't want her to use it if we weren't sure if we were going to see any results yet. So we did wait a few months before she started testing again. But thankfully, when we did start testing again, we immediately saw that she was having ovulatory healthy cycles, which made me so happy. But even more importantly, she told me, because I asked her again recently, whenever I knew that we were going to be doing this clinical conversation, she told me that her mood swings are much better. She does not have chronic fatigue. She just, in general, feels better. No more brain fog. And that's really why she came to see me. And so that's also what's important, is you need to remember the reason why the patient came to see you, because at the end of the day, you can fix their cycles. You can make them have a perfect hormone profile, ovulate on day 14 to 18. But if she was still feeling crummy, then we still have work to do. But luckily, she's feeling much better. And I was just very grateful that she, was patient with the process, and that we just stuck it out and we figured out what was going on, and, weren't just complacent with her insulin is normal. It's not just normal, it's optimal. And we kept digging. And since we kept digging, we found out what was going on. And now she's doing much better, which is just amazing. So it always just makes you feel so good when you really feel like you've helped someone. So that's pretty much concludes the case for today. So moving forward, whenever we have other topics that we feel like there's specific cases, again, with the patient's consent, of course, we'll just kind of be presenting these short little videos, just so you can kind of see the interventions and our thought process in real time. So I hope that you guys enjoyed and are looking forward to the last 2 episodes covering insulin resistance. Thank you so much.